Good afternoon, everyone. My name is Nombuso Mathe. I am a glaucoma specialist and ophthalmologist that is based in South Africa in the East Coast in a city called Durban. It's such a pleasure for me to be able to present this talk to everyone, and I thank Orba Cybersight for making this opportunity available. And really the purpose of this talk today is to assist you with just to have a simplified approach to the management of the pediatric patient from both a medical perspective as well as from a surgical perspective. So many of you and many of us who work with children regularly will be familiar with this scenario. And I'm sure you will all agree that a special skill is required to quickly build a rapport and gain the trust of these precious little ones and their parents. Pediatric glaucoma management is one of the most challenging spheres of our work as ophthalmologists, for many reasons, some of which I will get into today. It can also be a very rewarding experience because it entails a lifetime worth of vision preservation when one is able to get it right. My talk will cover the epidemiology as well as the classification. And I will also touch on how to establish a diagnosis before delving into the management, and then we'll round up with a summary. And at the end, we will have a question and answer session. And I'd really appreciate if you can just indicate which country or city you're in with your questions. Childhood glaucomas, in essence, are rare groups of diseases, estimated to be in and around 17 to 43,000 cases per birth. And the majority of cases we know are bilateral, but often the disease can be asymmetrical. Most commonly diagnosed as suspects, which can then be followed by secondary glaucomas, and less so primary congenital glaucoma. But really, this picture can change quite significantly because there is a geography that can differentiate in terms of the presentation. So our colleagues in Egypt and Brazil may be seeing higher numbers of PCG. Pediatric populations are also a highly heterogeneous group of patients, and that's regards to their age, to their development, their overall development, as well as the conditions that they experience. And so prevalence is not an easy thing to establish, as it relies on population studies. And in children, we know that there are challenges with this, both from an ethical and just logistical perspective, as well as in terms of getting enough information from research. There are several types of childhood glaucomas, and all are highly heritable. And this does include your primary congenital glaucoma, such as primary congenital glaucoma and juvenile open-angle glaucoma. Also of note is the significantly elevated risk, reported to be around 50% for the development of glaucoma in the other subcategories of diseases. So genetic testing, it being much more widely available now, and where it is accessible, should be offered to families so that they have an opportunity to receive counseling and be tested. The Childhood Glaucoma Research Network classification system was compiled at the 9th World Glaucoma Association meeting in Vancouver in 2013. And it helped to define childhood glaucoma to encourage the provision of a consistent care and to enable standardization in the way that we assess patients, and also the way that we measure our results through trials. Also, this has been driven by the aim of improving treatment for this vulnerable group. The classification system categorizes childhood glaucoma into primary childhood glaucomas, which include the primary congenital glaucoma and juvenile open-angle glaucoma, as well as into secondary glaucomas, which account for the glaucomas that arise in relation to either non-acquired ocular or systemic conditions, those that are related to acquired conditions, and the category that's related to cataract surgery. Glaucoma may manifest differently depending on the age of the child, and an extensive inquiry into the history of the symptoms, the presenting symptoms, and the overall condition of the child may provide very valuable information in assisting us with our assessment of the glaucoma suspect or patient. Some signs and symptoms that can be elicited from the inquiry may include epiphora, photophobia, and blepharospasm, The age of onset of symptoms as well is important, as well as the gestational history of the child. A family history, which must include consanguinity, is important. We must look at the overall developmental history as well as the history of milestone developments, as well as ocular history and a history of other systemic conditions, because we understand that there are connections with systemic conditions. In our examination, we must do a full ocular anterior segment examination, which will include visual acuity, intraocular pressure measurement, the assessment of corneal changes, corneal diameters, and also the assessment of the angle. A posterior examination will enable us to be able to document the optic nerve changes and any other changes on the retina that might allude to things like retinopathy of prematurity. And then, of course, a general assessment. This is really to assess for any findings that may give us clues into syndromic conditions that are linked to glaucoma. When looking at PCG, or primary congenital glaucoma, clinical manifestations may look slightly different depending on the age of disease onset. And I make reference to its classification into neonatal, which speaks to development of disease within the first month of life. And then infantile, which is a classification from the first month to the second year. And then late onset, which would be those children that develop a condition from the age of 2. The neonate may present with corneal clouding, photophobia, and a reduced visual response, with or without ophthalmos. And the older infant may have the triad of symptoms as described of epiphora, photophobia, and blepharospasm, as well as reduced vision, ophthalmos, hypstria, or corneal edema. Juvenile open-angle glaucoma, on the other hand, may present very similar to the adult primary open-angle glaucoma patient, with no symptoms, and sometimes non-specific symptoms of a headache, epiphora, or decreased vision. The hallmark in this category of patients is that they often present with extremely high IOP, and it's not uncommon for those intraocular pressures to be recorded around 50. When we look at the secondary glaucomas, and specifically the non-acquired ocular anomalies related, anterior segment dysgenesis makes up this group of diseases, and this includes your Axenfeld-Rieger's, your Peters anomaly, as well as aniridia. And they may present with various clinical findings. Correctopia, polychoria, and posterior embryotoxin, as well as peripheral iris attachments, may be seen with Axenfeld-Rieger's. Where there may be an association with systemic features, we would then refer to this as Axenfeld-Rieger syndrome. And this may be characterized by midline abnormalities that involve the teeth, the nasal bridge, the midface, and the periumbilicus. Central corneal opacification and iridocorneal or lenticular adhesions are seen in Peters anomaly, which can come in varying severities as captured in its classification of type 1 or type 2. And where there are systemic associations, these can be referred to, we then refer to the condition as Peters plus syndrome. The mechanism of glaucoma in this group of disorders is a malformation of the angle structures, or they may present with an angle closure type of picture, or a combination of the two. Aniridia, on the other hand, may result in either an open angle type of glaucoma due to the maldevelopment of the outflow pathway, or it can also present with a closed angle picture, which may result from a migration of the iris tissue onto the trabecular meshwork. When looking at the non-acquired systemic diseases-associated secondary glaucomas, we've got Sturge-Weber as well as neurofibromatosis that have been described. In Sturge-Weber syndrome, patients may have a characteristic ipsilateral facial hemangioma or port wine stain, which may be harder to recognize in patients who have darker skin or pigmentation. They may also present with leptomeningeal capillary malformations, which makes it very necessary to do a complete systemic assessment for these children. Small children with Sturge-Weber may develop ophthalmos, and the mechanism of glaucoma in this category of patients is twofold. They may have angle anomalies in onset of glaucoma that is early, but in late onset, they typically have a raised episcleral venous pressure type of picture. And these mechanisms are important to understand as they can help to direct our treatment strategy. Neurofibromatosis type 1 is rare and may present with different symptoms such as cafe au lait spots, leash nodules, neurofibromas, optic nerve pathway gliomas, as well as osseous dysplasia. And the mechanism for glaucoma in this category of patients, it may be related to trabecular meshwork malformation, neurofibroma infiltration of the angle, or an angle closure type of picture that results from a neurofibroma infiltration of the ciliary body. Then coming to the group of glaucomas associated with acquired conditions. And there's a number of these conditions, and we'll start off with the steroid-induced glaucomas. These primarily occur with exposure to your topical and periocular or regional steroids, but the use of oral, inhalational, nasal, as well as dermatological preparations can result in steroid-induced glaucoma. The mechanism for glaucoma is an increase in resistance at the trabecular meshwork outflow due to an altering in the microstructure of the trabecular meshwork. There may be an increase in collagen and fibronectin deposits in the extracellular matrix, as well as changes in certain substances and enzymes in the trabecular meshwork, which will impact the outflow. Steroid response has been described to occur after a few weeks, but it can happen much earlier. And children, especially those yet less than 6, are highly susceptible to the development of steroid response, as well as patients that have an existing diagnosis of glaucoma. Uveitic glaucoma presents quite a challenge in the pediatric group, and often patients will require controlling of the inflammation with the use of immunosuppressive agents. The mechanism of glaucoma in uveitic patients is variable. They may have an open angle type of picture that may result from trabecular meshwork obstruction due to mediators or inflammatory materials. They may present with a trabeculitis type of picture that may be associated with a virus-associated inflammation. They may have trabecular cell dysfunction, and with long-term use of steroids, they may develop raised episcleral venous pressure. The angle closure mechanism may be seen as a result of posterior synechiae development or pupillary membrane formation with Bombay, as well as the development of peripheral anterior synechiae. Patients who have incurred trauma may have an acute or prolonged elevation of intraocular pressure. The mechanism of glaucoma in these patients may be related to uveitis or hyphema, angle recession, ghost cell glaucoma, or a dislocated lens, as well as epithelial downgrowth has been described. And lastly, in retinopathy of prematurity, glaucoma may develop later in those children that have had stage 4 or 5 ROP that has been treated. The mechanism of glaucoma in this category of patients is also quite variable and may be related to a combination of these possibilities, which include poor angle development, angle closure in the cicatricial ROP group because they can develop a fibrovascular membrane or obstruction, neovascular glaucoma, or it may be related to glaucoma that develops following vitreoretinal surgery as a consequence of post-operative inflammation, which results in the fibrosis of your angle structures. They may also develop synechiae, as well as the use of tamponade related to the vitreoretinal surgery may trigger the development of glaucoma. And of course, we mustn't forget that they often are on steroids, and chronic steroid use can induce a steroid response type of picture. With this category of patients, the last category of patients that are the glaucomas that follow cataract surgery, this remains a significant challenge and may occur insidiously. And reports have been as high as 59%, which then warrants a continuous monitoring of children after cataract surgery. Risk factors include young age, especially under the age of 9 months, more specifically under the age of 3 months. So patients that have had cataract surgery under the age of 3 months. Other risk factors include microcornea, anterior segment dysgenesis, and the mechanism for glaucoma appears to involve an obstruction of the trabecular meshwork, either from inflammation or an anterior repositioning of the iris. A narrowing of Schlemm's canal and the anterior chamber angle has also been described as a mechanism, as well as the possibility of a toxic reaction of the vitreous on the trabecular meshwork. This was a study that was done by a group of surgeons in our unit, led by Dr. Nadesan, one of our specialists. And they performed a retrospective observational study, which aimed to look at the incidence of glaucoma over a 2-year period. And the criteria that was used for diagnosis followed the recommendations of the Childhood Research Network criteria. 155 eyes were recruited into the study, 133 of whom received intraocular lens implants, and 22 patients were left aphakic. 86% of the patients that were operated before 12 months, and all patients had had posterior capsulotomy. 94% of the patients were of African descent, and the remainder were Asian. So the results of the study found that 14 out of 155 eyes, or a total of 9%, developed glaucoma, which was bilateral. And of these patients, 4 were pseudophakic and 10 aphakic. So which speaks to the debate around whether intraocular lens implant truly does have a protective mechanism. And there isn't clear consensus around this. The study did show a strong association between the development of glaucoma following cataract surgery related to the early age, aphakia, and microcornea. The Childhood Glaucoma Research Network also provided definitions to aid us with diagnosis, again, driving the message of consistent and standardized approach to diagnosis and care. They have suggested the application of 2 or more identified features to diagnose glaucoma, which include a measurement of intraocular pressure and other clinical features related to the optic nerve head, the corneal changes in myopia that do not align with normal growth, and in older children, incorporating perimetric findings. I do perform optical coherence tomography in older patients who are cooperative. So where only one of these features was seen, the patient was then classified as a glaucoma suspect. There are a number of diagnostic tools that aid our assessment of the pediatric glaucoma patient. We have different types of tonometers available to us, which include the Perkins, which is my personal preference, as well as tonopen and rebound tonometry, such as the iCare. And of course, older children, we should try and get a Goldman tonometry reading. And it's always a surprise that just with a little bit of encouragement, you're able to get a measurement from these children. The SHIOTS was previously a tool that was used, but it's fallen out of favor really because it provides inaccurate measurements, especially in children, as they have reduced scleral rigidity. What rebound tonometry has done for us, it's changed how we do things significantly, in that it has reduced the need for examinations under anesthesia, as we can get intraocular pressure measurements or estimates, even in very small babies without needing to take them to theatre. And it is important to remember that a crying baby should be avoided, as IOP can be elevated, and that at extremes of pressures, your rebound tonometry becomes slightly less reliable. It can be off by about 2 to 3 millimeters of mercury compared to applanation. Rebound tonometers are now available that can assist us with supine position, measurements in supine position, and they've been found to be agreeable with Perkins. And the tonopen has been found to slightly overestimate when compared to Perkins. Corneal thickness does influence reading, and it may be better to confirm with applanation when you're faced with different corneal thickness measurements. When performing an examination under anesthesia, one needs to be aware of the effect of the anesthesia or the anesthetic agents on your intraocular pressure, and its most inducing agents will reduce the IOP once they are established. Corneal diameters are an important measurement for children under the age of 3. As the cornea enlarges as a result of the high pressures, which results in ophthalmos, due to the elasticity of the still developing eye, a change in corneal measurements can provide a very early sign of glaucoma. So diameters are above 11 millimeters in the newborn, above 12 millimeters in a 1-year-old, and above 13 millimeters in a toddler suggest glaucoma. And as the child gets older, the collagen fibers become more rigid. So they don't develop buphthalmos or changes as much in their cornea. The corneal changes as well as the buphthalmos also contribute to a myopic refraction. Elevated IOP can cause a stretch of the eyeball, or stretching of the eyeball, causing it to elongate, which leads to myopic changes, as well as changes in the axial length, which are important signs as well. It is also important to remember that normal axial length growth continues till about the age of 12. And in myopia, it can continue beyond this. It can be quite challenging to separate glaucoma related to myopic progression from normal myopic progression. With glaucoma, the progression is more rapid and will likely be associated with other features, such as raised intraocular pressures or other symptoms such as tearing and changes to your optic nerve. Whereas with myopic progression, you are not going to find you won't see these other findings. Compared to normal myopic progressions, it tends to be more gradual in terms of the progression as opposed to the glaucoma progression. And so the estimate has been given that with normal progression, you're looking at about a change of 0.5 to about 1 diopter per year. But with glaucoma, you can get changes within a couple of months and up to 2 diopters per year. Older children, whilst they may not have changes to their cornea diameter, they can continue to get an elongation of their eye if the pressure remains high, and this can worsen their myopia. So we must look for associated high IOP or suggestive optic nerve changes. Pediatric perimetry for small babies is not yet commercially available, but there are some prototypes that are under development. Eye movement pediatric perimetry is another strategy that has been used to determine visual field sensitivity in children through observing natural eye movements. And for older children, video game-based visual field assessment tools, or your traditional perimeter if they are cooperative. And there are some units that have pediatric testing capacity built into them. When considering preparing for an examination under anesthesia, the most important is to make sure that you plan well and engage with your pediatric anesthetist. Of course, the priorities will differ between the anesthetist and ourselves, where your anesthetist will be concerned around the exposure to anesthesia, as well as emergence and stability during anesthesia, whereas we're more concerned around assessing the intraocular pressure and assessing the rest of the eye. The other important factor is to counsel the patients about what your plan is. And sometimes planning for an examination under anesthesia together with a definitive procedure is better in a way to try and reduce the exposure to anesthesia. It's important that you ensure that you have all the necessary tools, and your choice of anesthesia is another variable. This you can make together with your anesthetist, and remembering that all anesthetic agents, once established, will reduce your intraocular pressure. So it is better to check your pressure just after induction. Pre-medication is not always warranted, but if it is required, midazolam has been found to have a little effect on intraocular pressure. Ketamine has shown to provide most stability of IOP measurements, though there have been some reports of it causing increase in intraocular pressure. Some of the concerns really is that it does induce a dissociative hallucinogenic effect, which both ourselves and the pediatric anesthetists are not happy about. Most anesthetists are very happy to use inhalational agents because they're preferred as they give a rapid onset of induction, as well as the patient, especially the pediatric patient, can have a rapid recovery after your examination. Most of the agents that are used seem to cause a minimal change, or reported to cause a minimal change to intraocular pressure. But for your benefit, rather do your IOP very soon after induction. When looking at airway management, it's important to know that intubation stimulates your sympathetic system, which can cause an increase in your intraocular pressure. So a laryngeal mask has been found to have less of an effect, But of course, the choice between a laryngeal mask and intubation will rest largely with your pediatric anesthetist, especially for the smaller babies under 5 kgs who may not be amenable to the use of a laryngeal mask. Your choice of tonometer is based on what you have available. So my preference is a Perkins. The important thing is that you try and use the same device for accuracy and for consistency. Lastly, I try and avoid any undue pressure on the eye. So I avoid using a speculum, especially when I'm going to measure the intraocular pressures, and I avoid to manipulate the eye too much, whether it's indentation or any other test like that, because it can impact your intraocular pressure measurement. So our management strategies include medical, laser, and surgical treatments, and the decision for which is really guided by the type of glaucoma that you are managing, the age of the child, and their visual potential. Pediatric glaucoma really is a surgical disease. As often, there is less favorable response to topical medication compared to adults. And of course, we know that the effect of the medication wanes over time. And when we have to consider the number of years that we have to try and fight for preservation of vision, and knowing also that children are more vulnerable to side effects of the topical medication. Also, in younger children, we are far more limited in terms of the choices that we have. There are also issues with installation of drops. So some parents do struggle or do find it challenging to install drops. I have parents who have thought that it was sufficient to just place the drop on the eyelashes. So these are important discussions to have with the parents to ensure that they are practicing good behavior and practices when it comes to drop installation. And lastly, certain glaucomas, such as your primary congenital glaucomas, have shown very high success rates with surgery. In terms of the treatments, we have a number of treatments available to us, a number of classes of treatments available to us. The prostaglandin analogs, such as latanoprost, bimatoprost, travoprost, are considered safe to use in children, especially with good effect in the juvenile open-angle glaucoma patient. Patients do experience some side effects, which include the elongation of lashes as well as iris pigmentation, but we rarely see the prostaglandin-associated orbitopathies in children. Your beta blockers are often first-line agents in many parts of the world, especially the non-selective. These should be avoided in premature babies and should be used with caution in children used in caution with children, and one should have a preference for a lower strength. And they are contraindicated in patients with asthma or other respiratory issues. Other effects to look out for include mood changes, depression, lethargy, and children often easily show changes in their behavior. And if you inquire a little bit more with the parents, you might be able to elicit this in the history. With regards to the alpha-adrenergic agents such as brimonidine, these are contraindicated in children under the age of 6 due to their ability to cross the blood-brain barrier and affect your alpha-2 receptors, impacting or decreasing your sympathetic nervous activity, resulting in a sedative effect. And children with developing nervous systems can be more affected. Somnolence can occur even in older children, and it is important to ask about a history of drowsiness following installation of drops or drowsiness at school. They are known to cause bradycardia, as well as a lowered blood pressure, which are notoriously overlooked symptoms. And rarely, patients may develop a hypersensitivity reaction. Epiclonidine or alpidine is much more preferred for children, as it has less systemic effects, as it acts more as a local agent with less systemic absorption. Your carbonic anhydrase inhibitors can be used with caution in children for systemic doses. We're looking for children under the age of 12. We're looking at weight-adjusted dosing of 8 to 30 milligrams per kilogram per day in divided doses. And whether you're using them topically or systemically, they can result in metabolic acidosis, fatigue, and they have been shown to trigger asthma, particularly the systemic carbonic anhydrase inhibitors. Rho kinase inhibitors have not been approved for use in children, and safety and efficacy has not been established. In fact, there was a case report that was recently published of a 4-year-old that had been started on a rho kinase inhibitor, and after 4 months of treatment, developed 6 diopters of corneal flattening, which reversed once the agent was stopped. And then your latanoprostene bunods as well are not approved in children, and safety and efficacy has not been established. What's important again to remember is that with a topical medication, we will have a waning effect in children over time. We have a number of laser procedures and treatments that are available to us, but very little data when it comes to use in children. Most of us are familiar with continuous wave or cyclodiode laser, which has been used successfully, especially for refractory glaucoma. The concern with this type of laser is that it can cause chronic inflammation as well as chronic hypotony. There have been some reports of use of micropulse in children, and it's been shown to provide a better safety profile, but it has been demonstrated to be less effective in children, even though we do have limited data. And the finding in one study was that there was a 22% success rate at 1 year. And this was related to the fact that the ciliary body regenerates much quicker in children. There have been some reports of success with endocyclophotocoagulation, though again, we've got limited data. And really it was being used for the treatment of refractory glaucomas. And then lastly, with selective laser trabeculoplasty, we have limited data, and the feeling has been that the outcomes are generally poor for younger children, but there are some reports that are coming out of effect that has been seen in the older group of children, the juvenile open-angle glaucoma patients, as well as in patients that have steroid response. So there have been some response shown in terms of treatment for patients with steroid response. When looking at our surgical management, again, we have a number of different options available to us. And the choice of the agent or choice of procedure will be informed by the type of glaucoma, the age of the patient, and the severity of the disease and the condition. These can be grouped into procedures that target the angle or the trabecular meshwork, as well as those that bypass it. Whilst adult glaucoma has seen many developments, child-related or pediatric glaucomas have not seen much development in terms of surgical procedures. And of course, there are ethical issues around testing out techniques or devices in this vulnerable group or enrolling them into studies. And it's simply not possible to just translate what we do for adults to children. So our options do remain limited to your angle-based procedure, as well as filtration or tube shunt surgery. As we know, surgical outcomes in the pediatric group are notoriously poor. And this is related to their immature immune systems that drive an exaggerated healing response. And of course, there's still the question around the use of antimetabolite, and there is no consistency or consensus around that. Examples of angle-based procedures. These are suited for certain types of glaucomas due to the underlying pathophysiologies. These examples include your primary congenital glaucoma, your juvenile open-angle glaucoma, your steroid response or steroid-induced glaucoma, and your uveitic glaucoma, but specifically the open-angle type. These strategies will work as far as the disease process has not involved the rest of the outflow pathway and is just limited to the trabecular meshwork. But once you have a trabecular collapse of your Schlemm's canal or fibrosis of your collector channels, then these angle-based procedures will not work. And this has been seen and can be seen in advanced glaucoma. Episcleral venous pressure needs to be normal and not impacted. And once you have raised episcleral venous pressure, it makes your angle-based procedures inefficient as well. And again, advanced glaucoma patients can develop raised episcleral venous pressure, as well as patients who are on long-term steroid or have steroid-induced glaucoma. Angle-based procedures include goniotomy, which relies on the use of a hypodermic needle or a 25 gauge, that is what I use, or a goniotomy knife, which enables you to incise the TM as wide as possible. And this treatment has been offered to patients with PCG up to the age of 16. We also have trabeculotomy, which can be performed externally using your rigid trabeculotomy probes, or using a fiber optic microcatheter that enables us to perform a 360 canalization of your Schlemm's canal. So you get 360 degrees of trabecular meshwork incision. Your trabeculotomy probes only give you a total of about 148 degrees of trabecular meshwork incision. And lastly, we have gonioscopy-assisted transluminal trabeculotomy, which is an ab interna procedure where we use 6-oproline, 5-06-oproline to cannulate your Schlemm's canal internally. Again, provides you with about a 360 degrees of trabecular meshwork excision. There has been a study that was reported that found that 360-degree trabeculotomy provided much better long-term success when compared to goniotomy or your traditional trabeculotomy. We also, when looking at your trabecular meshwork bypassing surgeries, we've got your tube shunt surgeries, trabeculectomy, and MIGS. With regards to MIGS, there's no reports of approved MIGS in children, and there's insufficient evidence for their use. Again, we are faced with high failure rates related to pediatric healing response, and the use of antimetabolite, anti-VEGF, or beta radiation is not uniform. So we do not have uniform or consensus around the use of these devices. We have the options of valved and non-valved shunts, which include the armored valve, the Maltino valve, the Barfelt tube, as well as a newer addition to the family, the pores glaucoma implant, which has become my personal choice in terms of shunt surgery in children. There has been published reports of 1 and 2 year success rates of up to 81%, qualified success rate of up to 81% with the use of a pores glaucoma implant. The difference with the pores glaucoma implant is that it elicits less encapsulation, as it provides a scaffold under the muscles, and because of its low profile and material, it elicits less of a foreign body type of reaction. It is a non-valve shunt, so it does require a stent, a Proline stent or nylon stent 6-0, which would probably need to be removed at some point once we have established scarring that can provide sufficient resistance for aqueous outflow. The stenting is done at the primary surgery. Trabeculectomy remains a choice of surgery, particularly in areas where shunts are not available, and there are still many places in the world where shunts are not available. I've just come back from a hospital-based training in Zambia, and that is an area where shunt surgery is not available, as well as Malawi. So for those colleagues who do not have access to shunts, trabeculectomy becomes their option. And this can be combined with trabeculotomy. This is often a procedure done in some cases where trabeculotomy is performed and the flap is not sutured tightly, and mitomycin or other antimetabolite is injected to create a bleb in that area. In the end, the procedure that you are able to do is the best you can do for your patients, unless you're able to refer the patients to somebody else. Trabeculectomy is associated with high failure rates, as well as high complication rates. And my personal preference is to not do trabeculectomy in children, really because of these reasons, and also the repeated need for examinations under anesthesia in terms of suture manipulation and removal of releasables. But in older children, I would consider trabeculectomy if we don't have enough options. As I mentioned, there are currently no MIGS devices that are approved for use in children. So some of the challenges that we face, whether it be trabeculectomy or shunt surgery, the large eye with the thin sclera, which can lead to leaking in your trabeculectomy flap, as well as peritubular leak with your shunts. And you may have to modify your technique for example, with your shunts, where you track your tube more in the cornea rather than in the sclera. We also can have issues of conjunctival retraction with tube or plate exposure. And of course, with young children who often rub their eye, can be a common occurrence. And of course, encapsulation as a result of the exaggerated healing response. There's also been reports of a significant waning effect of surgery, reported up to 50% over a period of 5 years. And it's been found that your non-valved tubes tend to do a little bit better long-term. And then, of course, there are the difficulties that we face related to managing the expectations of anxious and worried parents who are hoping for guarantees about their children's well-being that we simply cannot provide. The trick for me when facing patients is really to provide them with as much information as possible and to be realistic about what you're able to do and what you're hoping your outcomes will be, and helping them to understand that pediatric glaucomas in themselves patients will always require additional treatment. So there isn't a single treatment that we can provide mostly that can resolve the problem permanently. So some other issues that we need to consider include amblyopia as well as changing refraction. Often our focus can be so directed to managing the intraocular pressure that we forget about managing and ensuring that the child meets their maximum visual potential with appropriate correction, and especially in those cases where the disease is unilateral. And even in some cases, the disease can be bilateral, but it can be asymmetric. And then noting that refraction will change. Also, being able to provide the necessary visual rehabilitation. And there are colleagues, optometry colleagues, that provide low vision aids for children. So these are things to remember. The counseling of parents regarding future treatments is absolutely paramount. Most patients and parents are expecting that it's a one-stop shop. You will provide one single treatment that will resolve the issue, and not understanding that this is a long-term journey that you need to walk side by side with them, and that you may need to provide further treatment, whether surgery or medical treatment. And then another issue is the availability of integrated care. Some areas, such as the United Kingdom, really do this well in terms of having adequate social work support as well as psychology support. But I know in areas such as ours, we really don't have a well-integrated system that can help us continue beyond our clinical work in terms of assisting the patient and the parent, where children may require a different type of schooling system based on their sight impairment, and also just in terms of support psychologically and emotionally for facing a life of sight impairment and how to raise a child with this condition. And lastly, I would like to thank everyone for joining us today. In summary, we've covered the diagnosis of diagnosis and classification, and the importance of using a system that can help you to be able to be standardized in your approach. It's necessary to have a multidisciplinary team engagement when looking at the pediatric glaucoma patient. And this not only involves the pediatric anesthetist, but this will include your pediatrician as well for those conditions that involve systemic changes. The understanding of underlying pathophysiology is incredibly important, as we've seen that some of our treatment strategies can be directed to what the underlying mechanism for the glaucoma is. We have a number of available treatment strategies, but we must understand that even those strategies may fail over time, and that with medical and surgical treatment, there will always be a waning effect. Of course, there are challenges with surgery and complications, which we need to be aware of and be prepared to address and deal with. And then the importance of visual rehabilitation and correction to ensure that your pediatric patient is able to function as optimally as possible in their community and their environment. And then, of course, the counseling of the parent for realistic expectations around what we're able to achieve, considering the difficulty and complexity of the condition of pediatric glaucoma. And with that, I would like to encourage questions, and please would you share with us the city and or town or country you're in as I work through the questions. Thank you for your attention. I would like to ask about glaucoma and neck instability or front head syndrome, especially the Atlas C1, where jugular vein would be compromised. Would this cause high intraocular pressure? I can't really provide a clear answer for that because I'm not familiar with the scenario as a direct cause of raised intraocular pressure. But any vascular involvement or any vascular contribution can impact intraocular pressure, not necessarily from a high IOP, but from the optic nerve head impact in terms of there's a lot of dynamics that happen around the optic nerve head because you've got three pressures that are working together, being your intraocular pressure, your blood pressure, and your intracranial pressure. And so any impact in terms of your circulation may impact the health of your optic nerve head. I'm not sure whether it's directly this scenario would contribute to what the person who's asked the question has. I should think, though, that if you have an impact on your jugular vein, it may influence more the circulation dynamics. Another question. What is the youngest age in your experience that OCT measurements can be accurate for glaucoma diagnosis? Are there normative databases for pediatric or juvenile OCT measurements? So the way that I approach the adaptation of OCT is really to be able to measure within that patient's normative information. So I'm not necessarily looking at normative values against adult population. I'm looking to see if I can pick up any changes, because we understand that glaucoma is a change in optical coherence changes are changes that occur over time, and we're wanting to monitor more for progression rather than diagnosis. I'm not aware of any available units that have inputted normative data for pediatric or juvenile OCT measurements, but I think there is a lot of work that is happening around that. Can glaucoma cause effects to a person with eye pressures age 50 and above? Can it cause effects to the granny who used firewood smoke? So I think certainly above the age of 40, patients would be at risk for glaucoma, especially if there's a family history of glaucoma. If it's an African patient, they'd be at risk as well. And we know that in African patients, glaucoma tends to happen at an earlier age. The older a patient gets, the higher their risk of developing glaucoma. Specifically related to firewood smoke, I'm not aware that there is a direct link between firewood smoke and the development of glaucoma. But certainly from an age, and if they are based in Africa, I would consider that they would be at high risk of glaucoma. The next question. Thank you for this great presentation. I would like to know the value of genetic testing in those patients that do not meet the typical clinical criteria. I think where you have a family history of parents, I think that would be perhaps a good scenario. I don't think there is an indication if the clinical picture isn't pointing towards glaucoma, whether you would need to do genetic tests. I don't think it would be necessary, but certainly if there's anything that is suggestive of glaucoma or other syndromic changes, that would be where I would position it. Next question, at what age do you operate infantile glaucoma patients? As early as they present. I think the youngest patient I've operated was 2 months old. So as early as the patient presents. It is a surgical disease. The younger the child especially, they do better with surgery. And the response rate or outcomes rate with something like goniotomy, trabeculotomy in the younger age group is quite significant, reported up to about 70 to 80%. So I wouldn't hold off because of age. Another question, can children with juvenile open-angle glaucoma present with normal IOP? For example, you see a 9-year-old with optic disc cupping of 0.8, IOP consistently less than 21, not myopic, unable to cooperate for visual fields. Would you start treatment for this child? So I think the research network criteria really helps guide you in this, in terms of your IOP measurements, having more than one IOP measurements above 20. So we know that intraocular pressure can vary, and it can vary through the day. So depending on the time of day, sometimes what I do is alter when I take the intraocular pressure. So I might have a reading at different times in the days in terms of the patient's follow-up. So I'd plan an appointment at a different time and the next appointment at a different time, and try and work that. Where you're seeing optic disc cupping, I would also just make sure that you've performed a refraction, and with your refraction, check an axial length, because just a refraction alone doesn't give you the full refractive picture of that eye. So there are patients that may have an elongated axial length who, by all intents and purposes, behave like an axial myope, but your refraction may be not supporting of that. As for female glaucoma patients that started using glaucoma drops around 20 years old, what's the approach for pregnancy later on? So this is a whole other topic in terms of addressing treatment in pregnancy. So I'm not going to get into that so that I can address the questions that are specific to the topic for today. Approaches to low tension glaucoma in pediatrics, please. So this is really, I'm not convinced that there is a picture of low tension glaucoma in pediatrics. By definition, this has been, it's a disease of exclusion, and with a specific sort of criteria of patients in the adult population. For where I'm suspecting that it's glaucoma and I think it's low tension, I would look for another cause. So here you want to exclude other causes of neuropathy, which will include toxic neuropathy, assessing your vitamin B12, folate levels, and also making sure that there isn't a history of steroid use. I find this is something that is overlooked, especially if you're not inquiring about dermatological preparations and use of nasal sprays or asthma medication. Is high-frequency deep sclerectomy eligible in pediatrics? Yes, there are some reports of good success in the juvenile open-angle glaucoma patients. I think there are 2 reports that were published, quite a big study of about 60 patients. So yes, I don't perform deep sclerectomy, but yes, as opposed together with your trabeculectomy. Of course, with younger children, you'll be faced with the challenges of healing, exaggerated healing. The next question, a 17-year-old female with fluctuating IOP since 2021, as high as 41, cup disc ratio 0.2, had bilateral SLT early 2023, still to no avail, had right trab July 2025, so IOP today is 16, left remains 26. What is the best approach? My approach in this kind of patient will be an angle-based procedure. My choice would be a GAT, a gonioscopy-assisted transluminal trabeculotomy. The juvenile open angle glaucomas do really well with this type of procedure. Also, it is a procedure that helps you to preserve conjunctiva. So at a later stage, you may be able to offer a procedure that is conjunctiva based, but certainly that would be my approach in this case. Also, you want to exclude ocular hypertension versus glaucoma. So just having a high IOP with what looks like a normal cup disc ratio, I would also do an optical coherence tomography for this child, and just assess whether I'm seeing the typical findings that I would see in terms of nerve layer fallout that is in the trajectory of your axons, as well as involvement of your ganglion cells. I have a 12-year-old girl with IOP between 26 and 30 for a year now on MySopt. IOP is 26 to 27, cup disc ratio 0.4 in both eyes. Unfortunately, there's no facility to get visual fields or OCT for her. What is your advice? So MySopt, I'm assuming timolol. I would consider maybe changing the agent. I don't know if you have another agent available, such as your prostaglandin. I would also make sure that you are assessing the child's angles, doing gonioscopy to make sure that you're dealing with an open angle. From that, I think if you're able to just increase the medical treatment for now and watch for progression, that would be my suggestion. Will you implant IOL in small cornea aphakic eye to prevent secondary glaucoma? So there isn't really clear evidence that your intraocular lens implant is protective in terms of the development of glaucoma. However, aphakia seems to be a risk factor. So I think this would depend on the age of the child and the condition of the eye. This would be my approach to this case. What is the age in children do you recommend trabeculectomy? I don't recommend, I don't want to say I don't recommend trabeculectomy, because I know that many colleagues only have access to trabeculectomy. I do not perform trabeculectomy in small children. If I had to, I would probably wait until the child is stable enough for me to be able to manipulate the stitches on the slit lamp. And I find that category of about 13, 14, with convincing and coaching, you're able to manipulate stitches. So I do releasable stitches with my trabeculectomies, and this is the reason why I would do trabeculectomy if I needed to in the older child. What about no filtration surgery? I'm not sure no filtration surgery, whether that refers to tube surgery or which we have discussed, so I'm not sure about that question. Thank you from India, it's a pleasure. Hi to Christina in Romania. Thank you to the colleagues who are sending their thanks for the talk. Another question, do you have any experience of using oral sedatives in clinic to examine instead of using examination under anesthesia? So I think maybe I'm spoiled in my setting that we often don't need to you sedate in the clinic, but I know Valoron works quite well. We used to use that long ago. We would use that to sedate little ones in the clinic. I would like to ask, after OCT with adjusted age, should I start management right away or not, especially with kids with low IOP? I think I would want to ensure that I have a disease process, because this would mean a commitment to treatment potentially lifelong. Where you want to err on the side of caution, you could always just start on a single agent like a beta blocker. But I'm one who feels that it's necessary to establish a diagnosis. And even if it means taking time, if your pressure is not dealing with very high pressures, there's room to monitor and just make sure that you have the buy-in of your patient as well when you decide to do that. Please, do you have any experience of using oral? Okay, I've answered that question. What is the preferable medical treatment for patients or babies who underwent trabeculectomy but still have IOPs? So I was faced with this scenario 2 weeks ago when I was in Zambia. All the children that we examined had had trabeculectomy. Some as young as four months had trabeculectomies, and 100% of the trabeculectomies had failed. So so the purpose of my visit there was to help capacitate the surgeons to be able to perform angle-based procedures. So this would be what I would offer the child. Even if they've had trabeculectomy, there have been reports of success of angle-based procedures. What I tend to offer children now, the very small children, I offer them goniotomy and trabeculotomy. The slightly older child, the 3-4-year-old, I do a combination of goniotomy and GET. So I make a wide-ish excision of goniotomy and I try and feed the proline suture around. And I find that that has worked extremely well. So this would be my option for this type of a scenario. On what basis do we choose different drugs? So I think the age of the patient and the systemic conditions, you want to make sure that you are not exposing the child to anything that is contraindicated. And we know that under 6, your alpha adrenergics are contraindicated. Children with low weight, I find, tend to have much more side effects to treatment. So I'd be very cautious. I would also aim to use lower strengths in any of the drops that I use. And what basis, oh, okay, I think I've answered that. Is glaucoma 100% curable? So one of my mentors, Professor Penko, from Moorfields, used to say that goniotomy cures primary congenital glaucoma. And I think of our procedures, that is one, when we're able to implement the procedure timeously, you likely will never need to go back into that eye. So I've followed up a few patients who had goniotomies years ago and have never needed to have any other procedures. I also find that the juvenile open angle glaucoma patients that I've done GATs on have done really well, but of course we require long-term follow-up. And so in 20, 30 years, maybe I'll be able to answer your question. Since the IOP will be lower in general anesthesia, should we add 10 to 15 millimeters of mercury to Perkins tonometry IOP result during EUA? I wouldn't do that. I would rather aim to do my IOP measurement as early as possible. So within that first minute to 2 minutes. So what I often do as well is whilst they're gassing the child, I would check my intraocular pressure. And I find that works really well. But once you've gone beyond 5 minutes, you know that your intraocular pressure, so 5 to 8 minutes, your intraocular pressure will be low. So the earlier, the better. What are the options for a valve that has failed or that has extruded? So for a valve that has failed in children, I used to do quite a bit of resuscitation of the armored valve, where I would do a capsule excision with antimetabolite injection. So if you're doing armored valves, I use antimetabolite. I think it is futile. That is based on my experience and a lot of other colleagues, where if you do your armored valve without antimetabolite in this pediatric group, they fail. So that would be the first thing I would do. I'm less inclined to do the capsule excisions because I find that the demand in terms of the child's eye tends to be a little bit high. So even if there is flow through the armored, they still develop an encapsulation that's just not adequate in terms of managing their pressure. So remember, your armored valve has an inbuilt resistance of 10 millimeters of mercury, and then you add the resistance of your child's conjunctiva, which you can't really measure. But you know that if a child has got very thick tenons and they will proliferate following the trauma of your surgery, you're not going to end up with a pressure that is low enough potentially, and you're likely going to need to have topical medication together with your armored valve. How long does the patient have to be using local steroids to cause high IOP? So this varies. I find that with children, I see steroid response even as early as 1 week. So anytime where I see a change, and the key is also seeing a change in the other eye. So they often typically will develop an increase in pressure in the other eye that may be continuing to use their normal medication, and perhaps you've done a procedure in the other eye. There is a debate whether there is true steroid response if you have performed filtration surgery. I believe there is. The capacity of an eye to be able to maintain pressure will differ in children, and the capacity of your angle will differ. So if you've got further compromise because of steroids, you will see steroid response. So it's as early as at least a week in my experience. So this myth that it's only 4 to 6 weeks, I don't believe that. In fact, my patients have taught me otherwise. Please mention the pathophysiology of glaucoma and Sturge-Weber. So with Sturge-Weber, there's two potential pathophysiologies. The first being in the earlier onset glaucomas, they can get angle abnormalities or abnormal angle development. And in the later onset glaucoma, they develop a raised episcleral venous pressure. So understanding that is a capillary hemangioma, or a hemangioma that involves the episcleral venous plexus, they have raised episcleral venous pressure. And so that would be the pathophysiology for their glaucoma. I would like to ask you if there is ideal surgical procedure for LTBT little patients. I'm not sure what the LTBT means. Sorry, I would like to answer the question, but I'm not sure what LTBT means. Thank you for the wonderful presentation. Which normative data do you use for OCT? So I just use the standard normative data, remembering that glaucoma has very typical characteristic changes on OCT. So you aren't going to get nerve fiber layer fallout that involves the ganglion cell unless it's a myope. If there's no history of myopia, axial length is normal. If you have a change like that, it's most likely glaucoma unless you're dealing with another neuropathy. So I would use what I see in terms of picking up rather than relying on just having normative data. So I want to see, is there any demonstration of a nerve fiber layer change that appears to take the shape or appearance of a glaucoma, and work from that as a reference point. Greetings from Barbados. Hello. Have you noticed any correlation between eye allergies, eye rubbing, and large cupped dysracia or glaucoma? I think certainly continuous rubbing of the eye can definitely change the child's shape of the eye, specifically the corneas. In terms of that related to increased cup-disc ratio, I've not come across that. I would think if the patient has got some myopia, perhaps that could be it, and maybe some myopic progression could be part of what you're seeing that might be responsible for the change in cup-to-disc ratio. And of course, we know that patients that are myopic are at an increased risk of developing glaucoma. How often do you see other causes for optic changes and the child needed a brain scan? So anytime I see a picture that just does not look like glaucoma, so the optic nerve fallout where I see a pale disc, even when your neuroretinal rim is advancedly cupped, 0.9, generally they still, that little bit of rim that remains is pink. So where I see a completely pale disc, that already raises my suspicion. So I'm looking for a particular pattern in that sense. If I have OCT, I would be looking to see what changes are linked to that. So if I have changes that affect the papulomacular bundle, I know that it's unlikely glaucoma. Or if I have a change where we have talked about a red ring around your ganglion cell, that is typically not glaucoma. So these are the things that I would look for. Another question. Good afternoon. This is a colleague, one of my residents. Can you accurately measure IOP in a sleeping child in the clinic with IK or toner pen, or is a ketamine EUA preferred? I think simulating the most natural condition is the best. So if a child is sleeping in the clinic, I would work with that. That would be, I wouldn't push. If I'm able to get a measurement, that would be sufficient for me. And of course, it means you can avoid putting the child under anesthetic risk. What laser would you use for a child? So personally, the only laser that I'm familiar with in children is a diode laser. I am looking at a micropulse laser as an option because I do have it available, but I just need to have more evidence available to make that decision. I don't have access to endocyclophotocoagulation. I do have access to an SLT, and I do perform SLT in children, but that's probably at around the age of 12 or 13 because they're most cooperative. And my results are still kind of in the middle. So definitely there's evidence for cyclodiode, but I think there's a potential for SLT as well. And certainly from some of the reports with the juvenile open angle glaucoma that are convincing, I think it's worthwhile a try. I did bilateral trabeculectomy of a child at 10 months of age now. Now she's getting married. Congratulations to you. I wish I could be able to do a trabeculectomy that can last for that long in a young child like that. And I think the last question, in which ocular quadrant can I install valve tube? Everywhere. I mean, there's some patients that have 4 valves. I think as you start to go into the inferior space, you have a little bit more challenges. So infratemporal, you might have a little bit more issues of exposure. Infranasal tends to be associated with development of squints and alignment issues. So, but there is no restriction. I think you'd rather deal with being able to preserve vision than having to, miss the opportunity by not putting in a valve when you need to. So I've put in a valve in every quadrant. I think there's just some techniques. I do find that the infranasal space does not, and the supranasal doesn't give me as good an IOP, a lowering of IOP. And I think it's just that space is maybe contracted a little bit. And so, but in the end, we have to do what we need to do. So thank you to you all. I hope this talk has been helpful and insightful for you, and will at least give you some direction in terms of how to consider treatment strategies for patients. And I wish you all a pleasant afternoon or morning, depending on where you are in the world. And thank you for joining us today.